Center, Lagos. He is also a trained genetic counselor in sickle cell disorders, and of course, his special interests are care and management of children with the sickle cell disorder. So we go ahead to establish today's topic, and of course, in between, you can be a part of the show by calling us on the number 0700 923 923 923 or our WhatsApp platform 0817 313 6193. You're welcome to the studios, Dr. Tunji Alakija.
Thank you very much again.
Good to have you again. Leg ulcers. I have been privileged to see what it looks like, and it just really wasn't pretty at all. And I know the leg ulcer is different from the one that happens at the hip. I'm not sure what that one is called again.
No, avascular necrosis of the hip.
Hip, okay, that's a different thing entirely. Okay, so really, tell us about leg ulcers in sickle cell.
Now, at the outset, I will say that this is a very, very difficult problem to treat. And it's a quite very, very embarrassing situation for the patient. It affects him or her socially. It affects him or her financially. It affects him in psychologically, in every dimension you can think of. So it's quite a heavy topic that I think we should really delve into in deeper details, because those who have it as a complication, I know what they go through, the kind of embarrassment, the kind of suffering, the kind of pain that they go through.
But this is not something that just appears on the leg. There are signs and there are symptoms, right, before it degenerates.
Now the funny thing is that sometimes with sickle cell ulcers, leg ulcers, there is absolutely nothing to suggest that it is coming. It just happens just like that.
Just like that?
Just like that. The patient doesn't know it's coming. It happens just like that. But on other occasions, it may be preceded by a kind of a little boil, a little abrasion, a little ulcer. The patient may complain that something has been itching me. Which now later develops into the full-blown leg ulcer. In some cases also, there is a trauma. Patient has a wounded trauma that persists and is not well treated, and with the trauma a kind of abrasion comes in, an open wound, an infection comes in, and then the surface epithelium, the skin, that's really where the problem is. The skin being infected, it's debridated, and then the ulcer comes in. So those are the three methods. Either a small lesion that the patient doesn't think much about, a small boil, a small abrasion, sometimes a wound, a trauma, which is not well treated. But many times, and this is about 75 to 80%, nothing, it just happens spontaneously. So,
wow.
Yeah.
And there's just no way to, make sure to put it in check, because I'm one of the things that you say, or your advice as a genetic counselor that you are, is having routine checkups. Are these part of the things that you as doctors, try to see? Since you say the leg ulcers is something that can just come out of the blue.
Now, what we advocate when patients come for counseling is things to prevent it possibly from happening.
Okay.
But even with those ones, it can still happen, and that's where it is a bit difficult. But number one, we can tell them to try the best they can on their own to prevent it, which, if possible, it might help. But like I said, with all these, they can still. So number one, things that can bring it about, infection in those areas. So we tell the patient, if there's some sort of infection, come quickly to the hospital so we can treat you well. Number two, anything that brings edema, that is swelling of that area. In fact, swelling of those areas are one of the major things that brings it up and makes it complicated. And so we find that with these, and if the patient adheres to our counsel, the risk is reduced, but it's not totally excluded.
So you say it's a very deep topic. Tell us what we need to know about leg ulcers in sickle cell disorder.
Okay, number one is that when the ulcer comes in, the patient must quickly report to the hospital and not try home medication. Number two, things that worsen it are things like the patient walking a lot of distance, running, not letting the leg rest. So we advocate that even if he's going to be at home, rest in bed, elevate the foot of the bed, and stay there in bed for almost the whole day, which is difficult for somebody who is working government, working in a private, to be at home almost 24 hours, and it takes about 2 to 3 months. And the dressing and other things that need to be done is best done in a hospital. So daily dressing is one of the things we advocate. But for the patient to come to the hospital on a daily basis to attend the routine clinic, we have a dressing clinics there, daily dressing. It's not easy for most of them. Because think of somebody staying at Ikeja, and he has to come to Surulere, our Sickle Cell Foundation, every day for dressing. He has to run and catch a danfo or Okada, all this kind of thing. These things make it worse. So the more they walk and run, it makes it worse, the healing of the ulcer. So what we advocate is if we can admit the patient into the hospital and rest it, elevate the foot, make sure we dress it every day, give like tetanus toxoid to prevent all that tetanus from coming. Do the dressing daily. 3 months, the patient will be better. But how many patients can afford to stay off work for 3 months? How many patients can afford to be in bed for 3 months? How many patients can afford to be in bed with the foot elevated for 3 months? So these things make it difficult. How many patients have the money, finance,
To sustain.
to sustain for 3 months? So these are the things that makes it very, very difficult. But when they are able to come to the hospital, the first thing we do, we admit them. We tell the nurses, don't let this person move up and down. Must be in bed in the supine position. That is this place up. And then number is that the leg must be elevated. It's not going to be staying flat
At all times.
all the time. We want to prevent fluid. You see, if you are
Going to
standing,
the-
if you are standing, fluid gravitates downwards, and the ulcer is usually in the lower part of the leg.
Yeah, I was going to say that one of the persons I know I witnessed growing up as a kid, it was around his ankle.
You got it. That is where it is. The ankle bone is the bone in the ankle, and there are 2 bones on both
Both
sides.
sides, yes.
One is in the medial, one is in the lateral, the outside part. So most of the cases of leg ulcer is number 1 in the lower 1/3 of the lower leg, and number 2 near the ankle area, either on the inside or on the outside. And many times it's usually in one leg, but other times too, the 2 legs are both affected, the right
Wow.
and the leg. So it's quite a big problem, and we advocate the best is to be treated in a hospital. Psychological counseling is involved to let the patient know that gradually it may be. And gradually now we'll begin to talk about the treatment proper,
Right.
because there are some things that enhance the cure.
Okay.
But at the outset, I'll say that cure or no cure, leg ulcers tend to recur.
Oh,
Haven't healed, they will recur again. Haven't healed, they will recur again. So where are we going? So it's like almost like a life sentence for the person. So we'll talk very soon on the treatment,
how to manage
how to
and
manage
treatment.
it. Yeah.
Okay, so before we go to that, like stroke in sickle cell as a complication, you didn't mention stroke.
Okay.
Yes, you did mention, which was, surprise really to myself and to the whole of Lagos that, unlike, stroke as we know it to occur in adults, stroke in sickle cell as a complication could actually start in an individual who's as young as 2 years old.
Yeah.
Okay, so for leg ulcers, is it like that as well?
No. Leg ulcers is rare in children below the age of 10 years.
Oh,
We don't see that.
okay.
We begin to see it in the teenagers. That is from the age of like 13 to like 50. In fact, the statistics say that leg ulcers are commonest between the age of 15 and 50. That is young adults and adults, teenagers and young adults. You hardly find it in little children. And again, we find it mainly in patients with sickle cell anemia, SS. Not so much in SC, which is another sickle cell disorder, but it's a milder one. We see it more in the full-blown sickle cell anemia, SS. In fact, we see it in most cases of hereditary conditions where the blood is low level anemia in any patient hereditarily. That is so. We also find it in other cases where there is a low level of anemia hereditarily. So sickle cell is one of them, thalassemia is one of them, and other things like that. Where genetically and hereditary there is anemia. We see it in other cases of that, of which sickle cell is just one of the hereditary causes of anemia.
All right, it's 14 minutes gone past the hour of one, Lagos. Now is the time to be a part of the show. Express your concerns, your fears, comments, contributions, suggestions. I'm not sure about that, but hey, of course we can take that. Leg ulcers as a complication in sickle cell, it as a stigma is what we are talking about on the show today. And if you have one of such cases, you have experienced or seen one of such cases, or you're a parent, okay, and you have a kid who's probably complaining right now, because I would say that you're fortunate if you actually are able to see signs and symptoms, because I mean, as Dr. Alakija has actually said, it could just come out of the blue and voila, they tell you that your child actually has leg ulcer. But if at the moment your child is complaining of one itch or the other, and your child actually has the sickle cell traits in them, or rather the disorder, not the trait. The trait is the AS, right? Yes, you can ask your questions to our Dr. Alakija in the house. The number again is 0700 923 923 923. On WhatsApp, you can simply send us a message on 0817 313 6193. But really, I think for management, we need a lot of time, because a lot of people who are probably in it right now are wondering, what can I do, or what would I go through?
Now, number one, you need to come to a hospital, a good sickle cell hospital, so to say. Sickle Cell Foundation is one of such good places. But there are other hospitals too. We need to admit the patient for bed rest. Going up and down worsens it. Are you with me?
Right.
So if you can get bed rest for 3 months, chances of recovery is better. Number two, we need to give some tetanus toxoid, because it can, open wound, open ulcer can bring in tetanus, and that can be worse. It can be deadly.
Open wound, that's not healing.
Yes, it's not healing. So we need to give some tetanus toxoid.
Okay.
Number three, we need to be cleaning all the debris, the little debris around the ulcer. You clean it with water or some other things like that, so that there's no more infection. It can be clean. You see, the cleaner the wound, the better the healing.
Okay.
If the wound is cleaner and fresh, the chances of healing is better. Number four is that you need to dress it daily. In the good old days, we used to dress it with ULCERS solution and things like that. But these days, we have found something better than ULCERS that makes healing better.
Faster.
Yeah, and that prevents recurrence. It's a drug called Asmisol. It's made from Ghana. We use it now, and it gives very good result. Asmisol, ASMIS, Asmisol solution.
It's made in Ghana.
It's made in Ghana, but we can import it to Nigeria also.
Why are we not making it here?
We imported it at one time at the Sickle Cell Foundation, but it's finished now. So until we get some more supplies, Asmisol is still the best, better than ULCERS and all those kind of things. Number five is that we need to clean it daily with hydrogen peroxide also. We call it hydrogen peroxide. We use it. In the good old days, things like zinc, either by tablets or that kind of thing, helps, but it's not universal. In some cases, in the good old days, blood transfusion also helps. In some cases, they pour some powder on the lesion, like cicatrine powder. Some people use honey.
Hopefully they would dry up and soak the moist.
Sometimes honey was used at one time. Put some honey, put all this kind of thing, and zinc. But all these things are not very, very 100% effective.
For the leg ulcer.
For the leg ulcer. You give some antibiotics if the thing is smelling. Because if the wound is smelling, most likely some infection is there. So it's good to take a swab of the wound. Take it to the laboratory so that you can know what infection is incriminated and know which antibiotic will kill it. Yes. But if you cannot do this, just assume, we can intelligently assume that the infection is an anaerobic wound, and give the right antibiotic for that. So these are the things we use. And if there is pain, you give some painkillers also there. So with all these, removing the debris, all the little wounds, cleaning it with water, then dressing it We don't. Well, you can still use USOL, but the best dressing, like I said, is Asmisol solution.
Okay.
And if anybody can get that, it's imported from Ghana, is the best one. Another thing that is used is hydroxyurea. Hydroxyurea it gives good cure in some cases, but in some cases even Asmisol hinders the healing. So it's not a universally accepted thing. If some few cases say I use hydroxyurea, it helps, and some other people say it doesn't, it even makes it worse. So we need research, so to say. And the final thing we do is skin grafting.
What's that?
Skin grafting, in which we take some skin from some healthy areas of the body, like the thigh,
Right.
like the stomach, like the back. You take some skin from those areas and put the skin on the ulcer, because the ulcer is open. You need something to cover the skin. It's the skin that has problem. The skin around that ulcer is open, is debris, something kills it, so to say. So you need to cover it with another skin for the healing. That's what we do. So you take some skin from other areas of the body, like the thigh. You remove some skin from the thigh and place it on the ulcer. That should be the final cure. But many times, by the time you do this, we call it skin grafting. By the time you take some skin from some other good area and implant and place it on the ulcer, sometimes we get a good result. But sometimes after some time it breaks down again.
I was going to ask, isn't it likely to actually break down or somehow get infected, from the edges?
It's possible to break down again. In fact, most times after some time, it breaks down again. Concerning infection, you do your best, like I said, to prevent infection and so on and so forth. But the most important thing is that skin grafting used to be the final say. But because most times it breaks down again, it's not the final cure for leg ulcer. It's not an easy thing to treat, really. And you need to let the parents know that it takes quite a long time.
Speaking about it not being an easy thing to treat, I think I remember way back in the day, persons who suffer leg ulcers were said to have been suffering a curse from their village. I heard that a lot. You probably even hear it in movies, and you hear it from persons to persons. And then with time, of course, we got more enlightened and educated, that these were things, that came, with the sickle cell disorder. So first of all, you actually had to know if you actually had the sickle cell the sickle cell disorder, and then you're diagnosed with a leg ulcer. And well, we thank God that the world is evolving. We're getting more and more enlightened and more educated. Hence, one of the reasons for this show, the Surviving Sickle Cell, a show in partnership with the Sickle Cell Foundation Nigeria, and in memory of our blessed Tosi Buckner, who passed on last year, November the 19th. My name is Thelma Illams, the host of the show. You can actually be a part of the show if you have fears, concerns, questions, or contributions. The number to reach us is 0700 923 923 923. We're going to take a break now. When we come back, we'll be talking about its management, because Dr. Alakija had said if you actually suffer it, or you have someone who suffers from it and is able to heal, it's possible. There's a possible recurrence. But we want to talk about how you can actually manage it, because I want to believe that the degeneration could come from you not handling yourself properly even after having the first healing. So we'll look at management of the leg ulcer after your very first healing when we come back from this break. Don't go away, Lagos. For anybody still surviving sickle cell on your number one family radio, 92.3 Inspiration FM. Leg ulcer as a complication in sickle cell disorder is what we have been talking about. And before we went on that break, I did say we're going to ask Dr. Alakija, how does one who has actually suffered the leg ulcer and somehow recuperated, making sure that there is no recurrence, how does such a person manage his or herself?
Now, briefly, this is this. We're talking about how to maintain the healing.
Yes.
Things that provoke the healing must be put aside.
Like what?
Walking long distance, you must. Resting the foot. Even if you're at home, put it on a bed and elevate the leg component of it.
Is there a preference in temperature of water to bathe with?
No, there's nothing like that.
Okay.
Just raise the foot of the bed all the time. Make sure underlying infections are treated. Make sure that it's daily dressing with USOL or this new one is the best, as Misol, but we don't have it much. It can be imported from Ghana.
Right.
In fact, these are our humanitarians in Nigeria. They can import a lot and give it to most of these centers that deal with sickle cell.
Why are you talking about importing from Ghana, our next door neighbor, not us manufacturing our own?
Well, that will take a longer time. That will take a longer time. But it's already available in some of these chemists in Ghana. That's why we got our own festival.
To handle the issue of now.
Yeah, so we are talking
For
of...
future's sake.
Yeah, where are the Dangotes to help us financially? Where are the Folusho Alakijas?
Okay.
Where is the Femi Otedolas to help us and import a lot for the patients?
Dr. Alakija, because we're running out of time, I really want to ask you this salient question from Ayola Olajide, an editor of the Sickle Cell News. He says, you said leg ulcers are rare for those below 13 and those above 50. Have you, as a physician, ever personally come across anyone under 13 or over 50 presenting with leg ulcers?
I've never come across anyone over 50.
Okay, so it's actually
Yes,
unusual.
Yes, unusual.
Yeah. So, secondly, leg ulcers occasionally last throughout a lifetime for some. Is there absolutely no sure medication or cream to treat leg ulcers in sickle cell?
No, there's no cream. There's no medication. Antibiotics will help to cure if there's infection, which will make it worse. So that's why we need to check for infection.
Okay.
But the only thing is proper resting the foot. Not making sure that there's no edema or fluid around that place. That's why we alleviate the foot.
Okay.
And making sure that tetanus toxoid and other things are given.
Your last words on the show, doctor.
Yes, good.
Your last words.
Oh, the last word I'll say is this. Anybody that has leg ulcer, it's not an easy thing. Let the parents not overbearing on the children. It takes a long time.
Right.
If you can adhere with all these things we have said, definitely there'll be some improvement.
Right. All right, and we gotta go. It's 30 minutes already, gone past the hour one. Thank you so much, Dr. Tunji Alakija. We appreciate you. We look forward to another episode next Saturday, so join us same time, Saturday, 1 p.m. for another interesting topic yet on throwing more enlightenment on sickle cell and all that comes with it. My name is Velma Ellams, and this show has been in partnership with the Sickle Cell Foundation and in memory of the blessed memory of Tosi Buckner. Leg ulcer or not, always make sure that that loved one of yours, that neighbor of yours, that colleague of yours, you make them feel all the time like they mean the world to you. I gotta go, but we'll leave you with this one.